Right, let's go.
Okie dokie. Welcome everyone, good evening and welcome to the latest health chat at the Institute of Health and Social Care Management. Tonight we are talking global lessons in integrated care, and who better to join us than the fantastic Mark Britnell and the wonderful Roy Lilly. So Mark, Roy, have a good chat. Anyone, if you've got any questions, any comments, put them in the chat. I will be moderating that and I will bring them up at the end for Mark and Roy.
Thanks very much, Adam, and good evening, everybody, and welcome. If you're joining us live, then as Adam has said, please don't hesitate to put questions in the chat box. Don't put your hand up if you want to argue. I mean, don't go away from this opportunity and say, do you know what, I wish I'd asked Mark Britnell a question, because he's very rarely in the UK. We've caught him between going from somewhere glamorous to somewhere outrageous, and he's here and he's answering our questions. So seriously, don't go home and think, well, you are home, but you know what I mean. Don't say, oh, I wish I've wasted the opportunity. I really should have asked Mark about that. The other thing is, everybody we think has got a set of the slides that we're going to be referring to. We're not going to plow through them, but we're going to kind of dip in and out. We think you've all got a set of slides. If you haven't got the set of slides, Adam will put the link, the download link, in the chat box towards the end so that you can all get them before you sign off. So I think that's it. Mark, welcome. How are you doing? Where are you? I mean, last time I spoke to you, I think you were in Bermuda or somewhere, somewhere very down market. Where are you now?
No, it was Bahrain, and I'm now home, and I'm speaking to you from my kitchen, and it's not on fire, Roy. You'll be pleased to know.
Yeah, right. It's good. Well, it's great to see you. How have you been? I mean, traveling around the world. Did you manage to catch COVID? Did you manage to get rid of it?
I did. I caught it twice, actually, sadly. The first time, you might remember, we were asked to help with NHS London construct the Nightingale facility in the Excel. So I caught it very early on in the March of 2020. And then, funny enough, I caught it from my children about 4 weeks ago. Both were pretty pernicious, but the second one was more pleasurable than the first, because we simply didn't know what to expect then. And although, of course, we're still recovering, the country is, the NHS is, the workforce especially are. I was reminded during my second bout of COVID just how far science and the NHS have taken us, and sometimes we forget how much we've done and how far we've travelled. But yeah, I've had it twice, but I'm okay now. Thanks, Roy.
Right, and this, of course, now there's the issue of long COVID. Johnny Pearson Studdart's lot have done a report that I referred to in my e-letter this morning, where they're saying that the effect of long COVID is going to make people with long-term conditions even more difficult to look after. And I've woven that into the workforce piece. But I mean, it is quite worrying. So we've got a kind of set of circumstances that we don't really understand. I mean, the causality is not far from clear anyway. And if you couple that with someone who's like maybe, got unstable diabetes perhaps, or COPD, or even just a bit of asthma or what have you, the complexities that COVID brings with it in terms of what we're going to have to do to look after people is quite worrying. And of course, first port of call, where's it going to be? Primary care. Where haven't we got enough people? Primary care.
Yeah, I mean, I think that's very germane to the conversation we're about to have on integrated care.
Yeah,
because of course, we've got around 20 million plus people now with long-term conditions in the UK. Long COVID will just add to those pressures. Most developed health systems across the developed world are struggling with similar issues, and many now are trying to think about integrated or accountable care. I mean, what was interesting, of course, is to see the WHO's report last week that didn't say 6.24 million people had died. It was a much larger number than that. Yeah. I'm sure that's true.
Because we don't know what happened in India, do we?
Exactly.
Anyway, well, listen, we've got a lot to get into. I'm sharing my screen. You can all see I've got the first slide up. Look, the slide deck itself is over 20 slides, and each one is an absolute gem. And we'll be here, till next week if we go through them all. But I think perhaps let's sort of start with your first slide. I rather suspect that tonight we might be getting a preview of your next book, because every time I do one of these with you, we end up either turning your notes or your slides into an excellent book. Human did very well, didn't it? How many did you sell in Human? That was a good one.
So we sold in 106 countries, and I think at the last count over 20,000. And my first book, which is the book that you inspired when we had a health chat back in 2015, that sold in 109 countries and sold well over 30,000. So it's not bad for a health book, as you know, and I'm speaking to the master.
Yeah, well, I mean, they don't sell that. I mean, that's very good sales, really. So well done. Okay, right. Well, let's have a look at the. I mean, this is really this slide is. This is like your CV, isn't it? Really, in 13 years, in 81 countries, on 370 plus occasions. I'm amazed you kept a note of all this. I suppose what have you done? You've gone back through your expenses, or you can see what you've been.
No, I actually went back through my diary, because at some stage, as you say, I think I'll probably work up to a third book. And
well, I think you should, because we'll stop buggering about and gossiping. I don't see Mark very often, so we're having an old boys gossip. But this is unquestionably for me. There was some absolute gems in this, and there are your two first books, In Search of the Perfect Health System. I remember I asked you that question, didn't I, at the end, and you said there isn't one, but there are 25 things that they've all got. Yeah. And that was the origination, I think, of there is no silver bullet, but there is silver buckshot. Yeah. Okay, right. Well, I mean, where have you been? Let's just sort of, before we get into the integrated thing, let me sort of come back to that question that I asked you probably 5 years ago now. Where is the best health system? And I suppose the question now is, where is the best health system that survived COVID?
Yeah, well, the two that have always been my favourites, I might add a third now. And I'm not saying they're the best, but I think when you look at their track record in terms of GDP spend and their life expectancy and their outcomes, as far as we can tell, I would say Singapore and Israel. And both of those countries, for different reasons, also had, relatively speaking, a good COVID. You will remember that the UK was always trailing behind Singapore and Israel in terms of vaccinations. They are smaller countries, 7 and 8 million people respectively. However, I hope to demonstrate today that actually, through their integrated systems, the strength or the resilience of their health system not only put them in good standing prior to COVID, but also has meant that they can accelerate out of COVID more quickly. And then I might add another country reflecting on it, South Korea, but that's for a different day. But essentially what I try to do, Roy, and I'm sure we'll go into the next slide in a moment, is over 34 years since I joined the management training scheme for the NHS in 1989, I've always believed in integrated care, because it is on a prima facie basis the way that most health systems need to go. So strategically, it's obviously the right thing to do, but operationally, as we're finding perhaps already in the NHS, people, I think, struggle with the long-term vision and reconciling that to the short-term actions that need to be taken.
And it's an interesting point there, because the World Health Organization place heavy emphasis on primary care, don't they? They say, the investment should be in primary care, not in big hospitals. It's quite interesting. Liz Clark has just popped a little question in the box here. Liz, good evening, and it's thanks very much for joining us. Liz saying best health systems was defined by what criteria, and I think you've sort of hinted at the difficulty of what the hell is the best.
It's a short question that deserves a long answer. Yeah. But I would say, if you haven't read my first book, do. Each chapter can be read in the time that it takes to drink a cup of coffee. I talk about 12 different facets of high-performing health systems. The NHS gets a laudable and admirable mention. There have been so many different global reviews that try to produce league tables. I think they often create more smoke and heat than light. And so I decided to take a different approach with my first book. So the short answer to your question is try and read the book. Each chapter can be read in 5 or 6 minutes.
Liz, Liz, that's an outrageous advert, isn't it? I'm not sure we'll let him off with that answer. But I think we're going to have to. Right, now, I want to click through to the next slide, Mark, because these are all of the health systems that are mentioned in this slide deck. So in the United States, there's Giesinger, Kaiser Permanente, New York State, Montefiore. You know, we can go around the world. I mean, I know we're going to get into these in a bit more detail, Mark, but is there any that are sort of really outstanding?
Yeah, I mean, I think I've tried very hard to draw on my 34 years of experience, and essentially the 10 that I've mentioned here, some will be well known, mainly the North American ones to this audience, but then some perhaps won't be that well known, thinking about Singapore or Israel, for example. Now, I personally worked in 8 of these 10, so I can talk with some personal experience about what they do and what they don't do, their limitations, and also I think that the way that they hopefully help us think about how we want to implement it in the UK. And without going through the whole presentation this evening, Roy, I think we might skip to the lessons learned and then come back to the...
Yes, okay, that's cool. And I'm now going to demonstrate my prowess with Keynote, because I use Keynote, I don't use PowerPoint. That's for the children. And there's a keystroke thing I can do. What slide number is it you want to go to? 22?
27.
27, there we go. There it is. What do you think of that?
Thank you, Roy.
Okay, take us through this.
Okay, I think we start with something. We can go back to the 10 examples. So these are lessons that I've learned. Some of the oldest integrated care systems, such as Clalit, which is a socialized health system in Israel, have been going for over 100 years. Some have just been going for a matter of a couple of years. But the 10 lessons that I draw from these 10 systems are as follows. And I should say that I start from the basis of believing that the legislation that was just passed in the UK is strategically, of course, the right direction. There are many short-term problems that we might talk about that could knock that vision around a little bit. But I also feel that perhaps this current set of reforms has been launched with lower energy than perhaps we've seen from other reforms as well. It's understandable because of COVID and the financial problems and the waiting list problems. But I think if people don't aspire to be to something greater with integrated care, there's a danger it might flounder not through its own fault. So
can I just say, I absolutely agree with that, Mark, because I mean, everywhere I went during the Lansley nonsense, everybody they just wanted to get shot of it. They were doing workarounds. There was more energy working around the Lansley reforms than there was actually delivering healthcare in the Lansley reforms. And I think Simon, now Lord Simon, had it sort of right. He knew we had to get rid of it. There wasn't a lot of time, parliamentary time for new legislation. Of course, then we've had all the palaver with Brexit and COVID, so that's disrupted Parliament. But I think what he was trying to do, in fact, I know what he was trying to do, was to create a loose template for people to go into their own areas and sort themselves out so that they could work together. That I mean, I said right from the office, that's a bloody brilliant idea, Simon. You know, I'm sure people will jump at it. And then, of course, Brexit and COVID, it's not going to pan out really. And I just wonder, I mean, this is the ICS is not going well. I mean, let's be honest about it. There's a lot of infighting and argy-bargy and rows, and a lot of them aren't ready, and most of them are going to start life with or have started life with a huge deficit. It's not been a great start, is it? Do you think if we hadn't have had Brexit and we hadn't have had COVID, I mean, I know it's a bit of an esoteric question, but do you think that people would have sort of got it? I just don't think people get it now because they're worried about so much else.
Yeah, I'm not ready to give up on integrated care because I think strategically
No.
it is the only course that we can pursue over the next 20 years or so. But yes, in the short term, I think that the financial and waiting list worries post-COVID and the supply chain and inflation issues post-COVID and Brexit are all going to add to the pressure. But I think the short answer to your question is, if we accept that integrated care is the right strategic direction, and it has worked with the grain of the NHS, then I think we have to try and solve the short-term problems of money, workforce, and waiting lists in a way which is deeply collaborative. And I don't believe that any one institution can solve its waiting lists, finance, or indeed its workforce issues without thinking in an integrated collaborative fashion. So in short, I would approach the short-term challenges through the prism of integrated care between health and social care. And I would make sure that you actually learn by practicing in real time on these problems to build a stronger movement towards integrated care over the next decade and beyond. And I hope that's what we're going to see, because if we don't, they will, I think, fall back into the 28 strategic health authorities that we had in 2003, 2004, 2005. And inevitably, they will be judged by their weakest link, not their strongest link, and they will be abolished. And I think
Can I just ask you, we've got 40, Mark. Do you think 40 is too many? If you look at, for example, Holland, they've got groupings of about 500,000, which seems to work very well. And some of these of the 40, well, you can do the maths yourself. I mean, they're quite small, aren't they? Do they have enough traction, do you think?
We've had so many different numbers which have never been completely right. I'm aware that some regions have a large number of ICSs. That may well shake down. What they do with their back and middle offices, of course, will be crucial to that. My own rule of thumb, which I pointed to in Search of the Perfect Health System, integrated care platforms of at least 1 million enable you to do everything at scale. So give or take, that would be my rule of thumb. Some that I'll show you today have larger populations. So I'm less interested in the number and more interested in the strategic resolve. And if we had time to go through the presentation today, but people have it anyway, you will see that the best integrated or accountable care systems do actually, they at scale centralize population health management, financial management, contractual management, workforce, infrastructure, information technology and digital. So actually it's what's behind patient-facing services that really drives clever, integrated and accountable care systems. And as long as ICSs do that, and I think they will be forced to do it anyway through the sort of financial efficiencies that are coming or indeed are already upon us, then I think they can proceed as long as they understand where they think they're going into the medium and the long term. And my concern at the moment is that there's no real vision now towards integrated care. People seem tired, they're a bit weary, I understand that. But without vision, the people perish, as you well know. And therefore, I think the short-term problems have to be addressed in a different way, which is deeply collaborative on workforce, money, and I think waiting lists as well. And I think that can be done. And some of these examples that we'll talk about tonight show that it can be done.
Interesting. You talked about the back and middle office, which kind of opens up a discussion about IT, digital, all that kind of stuff. I mean, I saw ICSs as a really good opportunity to get a very good digital strategy, have a clear idea of what we wanted to do, figure out how much of it we could afford and get on with it. But it's, I mean, digital now, when they put a wrecking ball through the existing infrastructure. We got Digital X has gone. It's now we've got 2 digital leaders where we had 1. I mean, all that looks a muddle. I don't know. I mean, a lot of people are saying, well, it's going to be, it'll end up with Epic and Palantir as the 2 principal providers, and no one else is going to get a look in. I don't know, but I don't get a sense that there is digital leadership.
Well, I mean, if you allow me just for a second, Roy, just to skip through these 10.
Yes, please do.
You'll see, without digital capability to segment and stratify the population at scale, you will never achieve integrated care. and you will not achieve the synergies that we expect or hope for between health and social care. Let me just run through these, and then we can go back to the example. So
yeah, well, number four is yeah.
The first thing I think to say, it's obvious, but it needs to be thought about more deeply, is that there has been a retreat from quality prior to COVID and throughout COVID. But every system, the 10 that I mentioned, start with their genesis about having the right care in the right place at the right time. And they actually developed integrated care, not as an intellectual theorem that was superior to all others. They bumped into it and created it along the way of the pursuit of higher quality healthcare. And that's very important to understand, because actually the heartbeat of many of these systems is trying to get it right first time for the patient. Now, the second thing is, there is no way you can do that unless, of course, as you know, Roy, you have multi-professional teams working across health and social care. Thirdly, you need a financial system that is not over-engineered, that is not too fiscally complicated, but puts bundles and capitation in their rightful place. And fourthly, then you need this digital infrastructure that allows you to basically draw data from client interactions in social care, patient interactions in healthcare, and hold them at a much higher level. And then, of course, you need guidelines which have been clinically developed through clinical consensus, and then shared accountability at point 6 for performance. And that includes clinical performance as well as managerial and organizational performance. You can't segment and stratify unless you've got defined populations. We know that 6 long-term conditions drive about 70% of acute healthcare spend. And of course, you need new partnerships where managers know how they can support clinicians do the right thing. The point at 9 is, going back to the earlier question about how do you define high-performing health systems. Well, it's either now the triple or the quadruple aim. It's been around for a long time. Better value, better care, better quality, better health. And of course, now you've got issues about the environmental impact as well in terms of ESG requirements. But behind also the clear vision, great integrated care systems really are very good at defining and spotting and managing out risk. And in this case, risk is patients who are not being looked after most appropriately, so their cost and their quality is not being controlled. And then finally, you need agility in terms of your workforce, and we're going to talk about that later on. Now, that's a very long-winded answer to your question, but essentially, if you put these 10 things together, and we have some of them obviously in the NHS, we could have all of them in the NHS as far as I'm concerned. The heartbeat, or the brain, if you like, of good integrated care is a digitally sophisticated system. Now, I'm aware of the conversations about the organizations you just mentioned, obviously 2 American organizations. Let's hope they're open-ended, that they can, there's a degree of interoperability which enables other local systems to connect. Of course, all of this is subject to tenders. Personally, I would enter long-term relationships with all sorts of different organizations, as long as they could give you population health management at scale, and as long as that was based on clinical protocols that transcend organizations. And we're not there yet in the NHS, and we could be. So I think ICS, in terms of their structure, are fine. We know that the British disease is that we like to reorganize every 2.5 or 3 years. I hope we can resist that. Who knows, with the next election coming along? But I wouldn't like to see integrated care perish on the back of finance and waiting lists. And I think there is a different way to solve finance and waiting lists and workforce, as I said, through more collaborative mechanisms. So in short, right, we should start building these.
Let me just
overnight.
Let me just, before you kind of upsum that, Sue Wald has popped a question.
I see.
You can see it, yeah.
No, I can't, but we went to university with each other.
Oh, I see. Well, okay.
She was in Swindon as the Director of Adult Social Care, I think.
That's right. Well, she says, hello, Mark. As a former Director of Adult Social Services, I'm really interested in how we can achieve parity of esteem for adult social care within the ICSs. Are there lessons from your international work?
Yes.
And I think someone else mentioned, I saw it earlier on, where they're saying, aren't these just going to be dominated by trusts?
Okay, well, Roy, that's a great question. I wonder whether we can go to slide 6 and 7 now that you've mastered the technology.
Yeah, sure.
Because if we can, I can answer Sue's question. So, Sue, out of the 10 that I mentioned, 4 are North American. One that I spent a lot of time in is Montefiore in the Bronx, which, as you know, is not a salubrious area of New York City or New York State. Now, most of the examples globally that you would consider to be high performing are sadly only concerned with healthcare. There are 3 which are different. This is the one that's been going the longest. This actually thinks about health and social care together. It was established in 1884. First of all, it was just a group of doctors in primary and secondary care that got together and formed an integrated provider organisation. Social care came on board much later on, but they started to work together. They built up trust at the grassroots. They worked out pathways of care for patients and clients. They then decided they gained in confidence, and they started to move from an integrated provider organisation into an accountable care organisation. They deal with a very deprived area in the Bronx. As you can see here, 65% of children are born into poverty in the Bronx, and life expectancy drops for 6 months every minute on the subway from the Upper East Side, which is, of course, Manhattan. You can see the alliances they built at point 3, and that small organisational chart shows you how they have, over time, integrated health and care. And if we can jump to the next slide, what's impressive about Montefiore, and by the way, what I try to do for the presentation is just give you 1 slide on the history and then 1 slide on the practice. So I'm doing these organisations a disservice in 2 slides. You can't really summarise an organisation that started in 1884 in 2 slides. But you can see here that they have basically tried on the right-hand side of the screen. They have looked at the causes of obviously ill health in terms of health gain or loss. And you can see the usual suspects where they are destroying years to life and life to years. And as far as possible, they've got 1 health observatory now. You can see at point 2. They're on top of it in terms of health and social care. That their ground force, their teams are multidisciplinary. They have 1 workforce. There's still work to do, by the way, with the local state, New York State and the municipalities, but they're getting there. And you can see that they hold themselves to account through transparency, and they have great data for care coordination as well. And you can see also they've got a very good leadership platform in terms of education and training. So they haven't got it completely right, but they've been going now for over 130, 140 years. And more recently, they've taken more contracts after Obamacare in 2008-9. That are really, they've got great values too. And I think they're trying to put into practice some of the things that we would like to do in the English NHS. So once again, I'm sorry.
Do you think they benefited from not having a legacy? Do you think they benefited because this is the way they started?
Well, yes
we're
and no.
trying to change.
Yeah, yes and no. I mean, they started with some visionary Jewish immigrants, to be honest with you, that were ghettoized in a part of New York, and so the force inside that organisation is strong, a bit like Clalit as well, actually, in terms of social justice and social equality. But what I would say is, Roy, they obviously operate in one of the craziest health systems on the planet in terms of American healthcare. So that they're not immune from fee-for-service, they're not immune from contractual disputes, but they try and get along, and it's their vision it's their true north that keeps them going. So I think the pressure's on them to perhaps conform to the way the American system makes a lot of healthcare organisations conform and perform. I think what they're doing in spite of that is quite laudable. And that's why I come back to, if anyone can be world class about this, I think it's the English, or I think it's the NHS, because we don't have some of those forces that press down on healthcare systems to the same extent. So yes, they've got vision. No, they're not perfect, and they have been knocked around. They still have fee-for-service contracts with insurers that demand that they pay fee-for-service rates, but they don't let that stop them.
Ruth Ashmore is asking, Mark, where does the primary care workforce model work well in an ICS model, and what learning should we use? I mean, it's, I don't know if it's the complete answer. You need to have your own answer, but it kind of, the answer starts here, doesn't it?
Well, let's go back to slide 5 on Clalit, because
slide 5.
Yeah, Clalit, please, if that's okay, Roy.
Yeah.
It's a great question. So I would say that's it. So I would say that as I say, my first book, I'm not, by the way, I'm not bragging about my books. I certainly aren't, but I think I've said in the books that Israel's a very smart, high-value health system. Yeah. It spends 7.3% of GDP, life expectancy of 84 years of life. So at a high level, great value healthcare system in terms of better health, better care, better value. You can see what they pay their GPs. And basically I've been to, as you know, I've been to Israel, and I think there are 3 or 4 4 providers, Mugabe one of them, and others. And you can choose which one you want. You can change if you want to. You go to the post office and use $1, and that's right. They have to take you regardless of whatever is wrong with you. And I must say, when people ask me the question, you know, where one of the best places I've been, I always say Israel, because it is I mean, it is an insurance system which I know puts people off, but it is one that has a great deal of equity and does work. Yeah, I mean, people don't know that Clalit was established in 1918 by orchard workers, and actually it was an orchard worker that had his arm severed, completely taken off. And the workers came together to provide mutual insurance and mutual healthcare provision. So its roots are deeply socialized, born of the trade union movement. And people obviously nowadays forget that that's where they came from. But the other thing they did, which was to answer the question, is they heavily invested in community diagnostics and primary care. So they've got a very interesting model where they put a lot of diagnostic capability and community care in. They front loaded, if you will, the investment. You can see what they pay their GPs, although I can tell you what they pay their hospital specialists, and it's not the same as the UK, so you can work that out for yourselves. But you can see here, I think, if Clalit was American, the whole world would know about it. And I think this is a very smart, accountable care organization. So it's got a population health system that sends clinical sentinel indicators into the cloud every night. They've built their own AI algorithms. They work on their population. Clalit is responsible for 52% of the population, about 4 million lives. Their AI works every night at risk, looks at the risk protocols by clinical condition, spits down indicators overnight to the community teams that go and see the patient and their families almost before they get ill. And if the holy grail of healthcare is to be wise before the event, not smart after it, Clalit is getting close to that holy grail. Yeah. And I discovered something very interesting. I was there. You talk about the diagnostics in primary care. If you think about endoscopy, I mean, at the time when I went, an endoscopy unit was about the size of a wardrobe. Now, of course, they've come down to about the size of an HP printer. But in Clalit, they had an endoscopy piece of kit that was the size of an electric drill, with the endoscopy thing and the bits that go on the end. And it was a small screen. You could put it on a big screen. You could store and forward it to somebody else to get an opinion. And they were doing endoscopy in primary care. Yeah. I mean, they've been doing that. I mean, Israel is still to this day the only country where primary care spend exceeds acute spend. And guess which year primary care spend exceeded acute spend? It was 1998. Wow. Now, I like these questions because it enables us to flip between the slides. Yeah. And if you just look at what they do, their secret sources, so they've got this great population health system, sentinel clinical indicators going up, AI whirring away, spitting down risk-adjusted patient contacts, directing community teams. The second thing, and you wrote about volunteers, I think, today, they've created this massive movement called Kamani, which means like me in Hebrew, where you've got patients and volunteers helping each other, creating patient empowerment. Thirdly, you've got a salaried, unified workforce between primary and secondary care, not social care, by the way. But then you've got a research institute that is pushing the boundaries of what we know about integrated care. And then they have partnerships which actually allow the state, because it's a tech-savvy state, to create new intellectual property. So as you can see, I'm quite enthusiastic about this.
I agree. And you just reminded me, where is it in Finland? I think it is, where you were talking about patients and volunteers. They do their own renal dialysis, and it's run by volunteers and patients. It's not a clinician in sight, and it's like a workshop and a club almost.
I'm not sure about Finland, Roy, but I know that happens in Denmark.
It's Denmark. That's right. It's Denmark. Where's it? Hoppending or some peculiar place?
I don't know. I've met the leader of their patient advocacy movement.
Yeah. But it's brilliant. You walk in there and it looks like a club, really. And you've got people working on lathes and painting pictures and stuff. I mean, it really is very good.
Yeah.
Sorry to digress, but it is interesting to look how other countries do things.
Yeah, I mean, they've been going since 1911, but they only really got going, I think. They built their own electronic patient record. It started in a hospital. It's now an electronic health record. And they really got going from about 2003-4 onwards. So you would say they've matured over 20 years or so. Some of it can be sped up. They've got a population of 4 million. They've got many more ambulatory care or polyclinics, as we would call them, or perhaps we call them community diagnostic centres now. They're a smart system, and we've written 6 different booklets looking underneath the bonnet of this. So if you want to know how they're financed or how their IT works or their workforce, you can, our publications, I'll send them to you. You can send them on to the viewers today.
Good. Okay, where are we going now?
And wherever you want. I mean, I think another system which is quite interesting is, should we go to Singapore, Roy?
Yeah.
So
Well, listen, you've been a big fan of Singapore for a long time. You spend all the time there as well. And I like the idea that if you chew gum in the street, you get 10 years in jail. I think it's a really good idea.
Well, they have a particular form of democracy, as we know. But if you go to slide 15, we can talk a little bit about that. But obviously happy to take people's questions as well and go wherever people want. Singapore, as I've said, a particular form of communist or socialist democracy, basically created a system for 7.5 million people. They started with 6 clusters and they've gone down to 3 now. Why do I use them as an example? Because when they threw out the British in 1958-59, like many countries, they wanted to show their national virility by building very good teaching hospitals. And Singapore has certainly got some of the best teaching hospitals in the world. However, not a lot of people know that 1 in 3 people now are over the age of 60. So these hospitals that were great symbols of their national power and pride and progress are now obviously full of older people. Singapore is a tech-savvy nation, spends only 4.2% of its GDP, average life expectancy of 83 years of age, different circumstances, but it's in terms of the power, it's always been situated with the hospitals. And they realised in their last strategic plan and their new one now to 2030, they had to basically unpack that thinking and the hospital. So they created 3 clusters, and each cluster then is devolved to what we might call place-based practice between health and social care. Single management of the hospitals, the health centres, primary care, community care, residential care. You can see 1 community of carers, 1 network of providers, 1 community health team, 1 population, 1 budget, 1 menu of programs, 1 set of assessment tools. They don't mess around in Singapore. Now, of course, they are less consensual than perhaps we are. We like to perhaps chat more and think more and change our structures. But essentially they are, and they've also got a workforce issue as well. Essentially what they're doing now is unpacking a 20th century model of care in an integrated fashion. Now, they're not there yet, but they also created, if you go back 1 slide to slide 14, Roy, if you can, that's a schematic for the country and how they're organised. But essentially what they did in 2018 is they created a very big brain that looks at the best examples of integrated care around the world and deploys once. So the Agency for Integrated Care, I've met them. They are light years ahead of anything else I've seen, possibly with the exception of the Research Institute in Clelit, but they are really on the ball, and essentially they are trying to implement the best principles of integrated care that I mentioned at the beginning of the presentation.
Mark, we must talk about New Zealand.
Yeah.
Because during COVID, New Zealand seemed to, come out as a bit of an example of how to do things. Lucinda, whatever her name is, the Prime Minister there, is hugely popular and remains hugely popular. Where am I? What page is New Zealand?
New Zealand, Roy, if you go to New Zealand, is page 12 and 13.
Okay, well, that's easy to go back to.
Yeah.
There it is.
Yeah.
Canterbury, and I suppose it's worth, for people who perhaps not across this, it's worth pointing out that there was a natural disaster in Canterbury and they lost their entire infrastructure. Or the hospitals collapsed. There was an earthquake, and the whole place was just completely destroyed. And I remember doing a program about it, and the doctors were working in the back of cars and in streets to keep things going. But so take it up from there.
Yeah, well, by the way, the 10 that I've mentioned, at least 7, if not 8 of them, their genesis was from a crisis, by the way. So that is interesting to think about. This, of course, was a natural crisis. Yeah, many others, it was a crisis of poverty or social dislocation, but yeah, their genesis came from struggle. Many of them came from struggle, and that's why they're, I know. The English NHS is like the English NHS, and people then think about, well, how far can you apply others? My own feeling after 34 years and 13 years traveling there is that every country has something to teach and every country has something to learn. But in Canterbury, you can see here, they've got a very good integrated system, but the health board, as was, I'll come on to, they've also had a reform, Roy. But as was,
I know, I've got a guy who writes for me. You can see his stuff in the right-hand column. He writes a regular column, and he's excoriating about some of it.
Well, they did have, I think, it might have been 17 health boards. They've centralised now, but perhaps we can talk. Well, I can tell you why they did that. I've been talking to their newly appointed chair, but basically, in the old structure. They were responsible, as you can see in point 1, for purchasing and providing and planning health and social care services. They used a concept called alliance contracting, so it wasn't all managed by one block. Their GPs are independent, although there's a co-payment, which people don't talk quite a lot about when you're comparing New Zealand with others. But they do have good community services. You can see here this schematic from the King's Fund. I declare an interest. I'm a board member of the King's Fund. It's a very nice schematic where everyone's happy and healthy. But essentially what it tries to suggest is they use models of care. If you go to the next slide, please, Roy, at 13, they've done it through consensus and contracting. So if you just skip the page there, and it's written in one of our publications, but once again, there are themes that come through. They have very clear pathways of care for patients and carers. They have a very good intermediate care system that enables them to manage acute demand. They have primary care at scale. They focus on educating clinicians for pathways, and they pay for people to step up and be clinical leaders. So once again, there's no real secret sauce there. However, the changes now have been about scale to what they can do at scale for. And there are always 4 or 5 enablers. And I think all ICSs need to do this at scale. It may start to bristle with some of the foundation trusts, who knows? I'm not bothered who runs them, but you need a clear, consensual, collaborative service at scale for workforce, for digital, for finance, for contracting, and for infrastructure investments as well. We haven't got that at the moment. Who knows what's going to happen now that the new chair of NHS England's obviously got into saddle, as it were. I know he's looking at target operating models, TOMS, and SOPs, standard operating procedures, and that may trickle through. But what the latest review of the New Zealand health system said, there were too many operating at a small scale. And of course, with a population of about 4 million or so, if you questioned me before about some ICSs being small in the UK, then they're really like primary care networks, if you want to draw a parallel between what New Zealand had and what the UK has. Or
they're like bridge clubs. I tell you what really interests me. Number 4, Mark, here. It's a small thing, but it's a big thing. It's like everything. The small things get bigger when you get closer to them. And it says practice staff and primary and pharmacy clinicians are paid $150 to attend joint education sessions. Are paid to join. 2 words there that we just don't understand. Paid to go and joint.
Yeah, I mean, and you know, they're not charities. They do it because if you've devised clinical pathways, if you're creating an information system to support the practice of good evidence-based clinical practice, and you want your clinicians to do it, and you're going to hold them to account, why wouldn't you pay them to be educated?
I heard something the other day that if you're a nurse here and you're a 6 or 7 and you want to become a district nurse, you do a course and you go on a district, and you come out and be a district nurse, you're a band 5, so you lose money. And then we think, well, why is it that we haven't got any district nurses? Look, I'm conscious of the time, Mark. It's 1:45, so I'm going to ask you, if you wouldn't mind, going to hack through some of the questions. So if we could just kind of hit them off machine gun. Phil Hawthorne's with us tonight. Phil, it's great to hear from you. I can't see you, but hi. Canterbury Point 2, that's the acute demand management system that is on your slide. It looks exactly like the Buurtzorg model. I suppose it's not a million miles away from it, is it?
No, it's not. I mean, the difference between the two, it's a great question, is that my understanding, it may have changed in New Zealand, I haven't been there for 3 years since the lockdown, is the Buurtzorg model, which we did KPMG helped to create back in the early 2010-11. Basically, they have a peripatetic group of empowered nurses who work seamlessly between the home, the community, and the hospital. So it's one nurse actually following the patient journey. In New Zealand, my understanding is that they have still different siloed nurses working in different areas, but they do collaborate to a much higher level. But I take your point, and I think you're right. Once again, empowering nurses to do more of what they can do, letting them really fulfill their professional vocation is certainly, I think, a key ingredient of integrated care, because we know at the end of the day, nurses drive integrated care protocols better than any other clinical specialty. And
as we were saying before we came on air tonight, the workforce problems we've got, I mean, one of the solutions is getting everybody to work at the absolute outside edge of their competencies and their license and their registration. You know, we've got to train nurses to do more stuff. But the trouble is, nobody wants to pay the training costs.
Well, just a word on that, Roy. The real, it's in my second book, that the real breakthrough there, you've just described with district nursing, all that's wrong with 19th and 20th century education, where you go up one pipe stove, you have to go down and then up again. So there's a better way called credentialing, where you can design training courses that give people skills in real time to do what patients or users need. So I think we need to be much more agile in terms of credentialing for workforce. We can come back to that another day, but that is one way through the impasse that we seem to find ourselves in at the moment.
That's a really interesting point. Okay, Sue Ward again. Thanks, Sue. On workforce, recruitment and retention is now a major issue that's being raised by social care providers. The social care workforce is characterized by low pay, poor career progression, and high runover. Yet social care has a skilled workforce. The current reforms and DHSC includes funding for training, but nothing to fund higher levels of pay or career progression. There are lessons from other countries who have a different workforce model for social care? Well, there are a lot of them, I guess, aren't there? There
are. And I think that you have to stand on the bridge when you're looking at health and social care, especially for elderly, frail. Personally, I think, look, I accept Sue's comment and point. I think building now proper business cases where you can see better value for paying people more to make sure that patients are properly cared for in their home, supported by community teams and technology. I honestly think we're going to have to cross that Rubicon, because if we don't, we're going to find that the health service is depleted, social care is depleted. You've got a new cap now through the legislation, and there will be no workforce to service that need. So I'm hoping that over time, ICSs will gain confidence to start experimenting with this. And one of the things, of course, that you always notice, whether it's the 5-year forward view or successive pieces of legislation, they never talk about workforce. And at the end of the day, that's what breaks or makes successful reform. So, Sue, all I can say is I agree, but I hope ICSs create or move into the space where they demonstrate this is what they need to do. So Birdsong is a very good example of having a unified clinical team servicing human beings, whether they're in their home, in the community, or at hospital.
And we've tried very hard to get Birdsong going here. And it's, I mean, there are some kind of examples of it, and a lot of effort's gone into it, but it's never really caught on.
I think that it's the old cliche: pilots never fail, pilots never scale. Yeah. So at some stage we're going to have to take a bigger leap. Okay,
Ruth Ashmore, she's made a comment. She said this community of carers really helped them to manage COVID-19. Well, that's true. Right, Phil Hawthorne, he's challenging us. He's saying, are all marks examples of smaller countries, and does that help? Well, actually, you use some examples in the US, but the US doesn't have a national health service.
I mean, thank you for that question. And the answer is, I mean, Roy and I, before the conversation tonight, debated whether I just give a presentation, which I think I'd like to think would be exciting, but it would be too much talking from me. The answer to your question is no, because if you look at New York State, where I worked for 5 years, that's a population of 21 million people. If you look at Sanming in China, one of the smallest provinces, it's still 2.5 million people. If you look at Geisinger in Pennsylvania, it's a population of 3.1 million people. If you look at Valencia in Spain, that's a smaller population of about 500,000. So it just happens that I talked about Israel and Singapore. The examples that I use are all of a sufficient size and scale to make integrated and accountable care real and to achieve benefits for patients and users. So I just got stuck on the two, but no, to answer your question, if we had more time, you can see different examples. Kaiser Permanente has a membership base now of 12 million people, so they can be very large or they can be relatively small. Yeah. The principles are the same.
But you do get, you somehow get to this magic 1 million, don't you? That it's big enough to do things and small enough to do things properly.
Yes. Yeah.
It's a really we got about 7 minutes left, Mark. Ruth Ashmore. Ruth, hi, Ruth. Thank you, Mark. Where does the primary care workforce model work well in the ICS model? What learning should we use? Well, you've given several examples of where primary care is. Primary care is the predominant success factor in these things. But would you pick one out?
Well, just another example as we trot around the world, if you even look at the one in Ribera Salud in Valencia in Spain, it's a public-private partnership, and they started with basically the hospitals were dysfunctional, the quality was poor, the costs were escalating. The government, which is a left-wing socialist government, basically tried a radical experiment, I think against their better instincts, and it seems to have worked. Costs seem to be 25% lower for management at least. And basically, when you look at those slides, Roy, if we can just turn quickly at this time, just to slide number 10, please. Yep. They basically tried to tackle the hospital, and guess what they found is they had to keep going. The efficiencies and the synergies didn't exist, couldn't materialize, were not sustainable unless they got into primary care, mental health and home care. So that's also a very interesting story. But the short answer is yes, you need a very strong primary care platform.
Yeah. And look at this, number 4, 20% of workforce pay is linked to performance and to organizations' results.
That's true.
Can you imagine that happening here?
No.
No, I was going to leave it rhetorical, but I agree. Right, Paul Batchelor. Good evening, Paul. A key element of improving collaboration lies with the education system. Given the entrenched professional regulatory controlled curricula, how would you go about using the initial training programs to bring about better care provision across the various crafts?
That's a great question. And it's a shame we've got 4 minutes left. Yeah. But just one reflection, one point. Our education system in healthcare globally in the developed world is in serious need of urgent attention. We are the only industry that I can see that spends 80% of our money on undergraduates and 20% on postgraduates. Think about that. 20% for the next 30 years of professional practice. It's crazy. We need to think about credentialing and actually picking these skills up sooner rather than later. I've just finished a piece of work in Toronto where they're building a new uber modern primary care medical school with all the clinical services and different clinical professions involved. It's a 4-year course. I think that this is the next frontier for us to really significantly re-engineer and revolutionize. So I agree with the comment, and there are some green shoots appearing around the world.
Yeah, that's Deborah McInerney. She makes the comment, which we could perhaps use as a wrap up, really, because it's a big philosophical point. Short question, big impact. This will depend largely on the leadership and also the financial flows in place. And, you know, we know when we try to work with local authorities before, it's just a row about cost shifting and how much we can make them pay for that we don't have to pay for. And of course, it's the leadership. And it has to be said that quite a lot of ICSs have had problems with sharing, with recruiting.
Yeah, I mean, I think, I do, privately, I worry there's not enough energy and vision from the top in terms of the vision for integrated care. I do think without vision, people perish. I think now we're facing 3 years up until the election and the year after, with very difficult fiscal waiting list and workforce issues. As I've said, I believe that we should keep that spirit of integrated care burning, and we should practice in real time on those 3 pressing issues in a fundamentally different way, which is about collaboration. I'm no fool, I'm not naive. I've been in healthcare for 34 years, but I genuinely believe that we can do this if we have, I think there are lessons internationally that we can learn from, and there's great practice across the United Kingdom. If you look at some of the work that's going on in Scotland, for example, and also Wales. So I agree with the comment, but I'm not ready to give up. And I think, you know, going back to this curious low energy that we feel at the moment, I'm sure a lot of it's to do with COVID, but I think that the historic journey of the NHS lends itself and points towards integrated care. And if we can't do it, we'll only have ourselves to blame.
I think that's a brilliant point to end on, Mark. I suppose the problem is the NHS, part of the success of the NHS is its history, but part of its legacy, but part of that is the difficulty we have in really making significant change. I mean, going from district health authorities to primary care trusts to ICSs, and they're all fundamentally district health authorities. You've got that level of management, and they're all more or less the same. We've wasted God knows how much money to go around in a complete bloody circle, really. But that's the difficulty. It's trying. I mean, if you think of what we can do with technology now, what you were saying in Israel, what they can do with machine learning, and how that they can interface that with the decision making. We have so many opportunities, and trouble is we have such a huge reluctance to really embrace real strategic change. Mark, listen, it's been fascinating to talk to you as always, and thank you for giving us your time. You can download the full slide deck from the link that I think Adam has put in the chat box. Please do it, they're free. And plagiarize them, and we'll call it research. Mark doesn't mind. Listen, when are you back on your travels, Mark?
I think in about 3 weeks' time. I'm off.
And where are you off to? Anywhere interesting? Or
Australia.
Australia. Well, yeah, you'll be
finally.
You'll see a lot of English people out there working in their healthcare system. They're all mainly Scots, the ones that I met when I was there. Listen, Mark, can we just say thank you to Mark? Thank you all for watching and giving us your evening. I hope you found it worthwhile. And it's just my job to say thank you very much. Stay safe, and hand you back to Adam Purnell.
Thank you very much. I mean, what an absolutely incredible health chat. It's so timely at the moment, integrated care systems. And, I come from the social care side of things. Obviously, Roy's health. side of things. And it's always wonderful to have these conversations in a productive manner, just hoping for the future that something different is going to happen, something new is going to happen, something's going to change. I think it's been wonderful. Everyone should catch up on this if you joined halfway through. I have put the slide decks in the chat. Shameless plug for our Learning Festival, which is coming up on the 24th, 5th and 6th of May. So if you do want to come down and see any of our roundtable discussions or panel discussions that are going on there, or John delivering his high performance leadership workshops, please do join us. But thank you everyone for joining us this evening, and we will see you at our next Health Chat.
Goodbye, everybody. Keep safe.